Linda, I want to welcome you to the CanVent Clinic.
Thank you.
I'm Dr. McKim. It's really nice to meet you.
Nice to meet you as well, Doctor.
Your doctor asked us to see you here because of your recent diagnosis of ALS.
I understand ALS has to do with the muscles and the nerves, but why would my breathing be affected? Why would I have to see a respiratory specialist?
Right, so here in the CanVent Clinic, we see anybody in the center who has a neurological or a neuromuscular disorder that might affect their ability to breathe. Remember, in the same way that your muscles that move your arms and your legs also control your breathing. So in your case with ALS, any muscle can be affected. So your breathing muscles are responsible for filling your lungs to get oxygen in and emptying them to get carbon dioxide out. So if those muscles are affected, then your breathing can be affected. So you need to come to see us here in the CanVent program so we can monitor you, provide you with advice and any therapies that are really necessary and helpful.
So is my cough also going to be affected?
Yeah, absolutely, it can be. In the same way that you need respiratory muscles to breathe in, you also need respiratory muscles in the chest wall and in the abdomen to contract forcefully in order to generate a high pressure in the thorax so that you can cough adequately. Similarly, muscles are responsible in the voice box for closing over, allowing that pressure to be generated, and then popping open really rapidly so you get this quick gush of air out, which will clear secretions from the airway. So any of these muscles can be affected, and therefore breathing and coughing can be impacted in a number of neuromuscular diseases, and in particular in ALS.
So is there anything I can do to, make my breathing better or make my cough better?
Yeah, absolutely. I mean, there's not a lot of evidence, really good scientific evidence for many of the exercises that we recommend, but it makes a lot of sense when you think about it. If you had a weak or paralyzed arm, it's likely going to become stiff if you don't put it through what we call a range of motion on a regular basis. Well, the chest wall is full of joints, not unlike your elbow or your knee. And if the muscles become weak, and remember that the respiratory system it's an elastic organ. It takes energy and strength to open it up, to fill it, and also to empty it. So if those muscles become weakened, then you won't be able to fill them adequately and cough. So if they become weak and the lung volumes become smaller, then the whole respiratory system may stiffen, just like a joint might. So if you're able to put it through a bigger or normal range of motion on a regular basis, then it's going to be more flexible. So that even in the context of weak muscles, they may be able to mobilize the chest wall and breathe more adequately. Or you can fill the lungs with a resuscitation bag like this, and you do what we call lung volume recruitment, where you're stacking breaths on top of each other in order to fill the lungs up, make them more flexible, and to improve your cough.
So my understanding is that I'll be using these breath stacking machines and stuff like that, and then I might need another kind of breathing machine at night, starting at night, and then I will go to needing that machine 24 hours a day, day and night. Is that real?
So, sadly, but if you think about it, if one needs to start at some point because there's some impairment and that impairment is going to continue, then yes, it tends to begin at nighttime alone, but gradually one feels shorter breath during the daytime, and that breathlessness may be relieved by using the ventilator for periods of an hour or two, but then those periods get longer until really you're using the ventilator through a mask up to 24 hours a day. Now at some point, one may have to consider whether or not one would agree to invasive ventilation, which is a much more dramatic intervention. That's using a tracheostomy.
So just because I have ALS, I don't automatically have to have a tracheostomy.
You certainly don't have to have a tracheostomy, but ultimately in ALS, one has to make a decision between invasive tracheostomy ventilation, which will allow for prolonged survival, or comfort measures, treating symptoms, so symptom management or palliative care, using medications for breathlessness, anxiety, and pain so that one is as comfortable as possible. And in fact, 95% of the patients that I look after choose not to have invasive tracheostomy ventilation for many of their own personal reasons, but I think primarily because they don't view it as a quality of life. But what people in the CanVent program that we care for need to understand is we will support whatever decision they make. It's up to them. Our obligation is to make sure that we help them understand as best we can what the possibilities are and what the implications might be. So nobody has to have a tracheostomy. Nobody has to use non-invasive ventilation for that matter. But we're in a position of offering those therapies to you if that's what you wish.
So I've just been diagnosed with ALS, and now you've told me about these breathing machines. How long do you think it's going to be before I need one?
It's really impossible to say. Everybody is different. It depends where the condition presents itself, whether it's in the arms or the legs, or whether it affects swallowing and speech. The time when someone's going to need ventilatory support is different for everybody. That's why we need to monitor you. That's why you're here and you'll be seeing us on a regular basis. So this doesn't come as a sudden, shock or crisis. It's something that we can monitor on a gradual basis and try and predict and always anticipate your needs so that we're going to be able to intervene with something helpful. So we just can't predict when any one individual is going to need this support. What we can tell you is that we'll be there to monitor you and help provide what you need when it's necessary.
So you mentioned mouthpiece ventilation. Can you tell me more about that, doctor?
Sure, absolutely. So I have cared for a number of patients over the years who have virtually no measurable pulmonary function at all, and yet they don't need an artificial airway. They don't need a tracheostomy or intubation. They can maintain their ventilation 24 hours a day using a mask at night, as we would treat, for example, sleep apnea with a bilevel device or a ventilator. And during the daytime, they use a mouthpiece. So this is a modified mouthpiece. There's a few different types. We usually use a little angled mouthpiece. And all of this is described in detail on the website. But in general, people will have a volume targeted ventilator mounted to their chair, because in fact most, if not all, individuals who are needing 24-hour ventilation are wheelchair assisted. So the ventilator is mounted on the back of the chair. They have an arm which fixes the mouthpiece in place, so they usually only have to turn their head a little bit in order to use the mouthpiece. They do need to be able to grip the mouthpiece effectively so that they can seal around it, so that when the ventilator gives them the volume and pressure, it inflates their lung properly and they don't just leak around the mouth. So they need to have essentially what we call normal or only mildly affected bulbar function. So their lips, tongue, voice box should be working very well so that they're able to do this. Similarly, these individuals can usually swallow normally without choking. So they can sustain themselves either with every single breath if they need to, or they might use every 5th or 10th breath if they have some degree of autonomy, to be able to breathe on their own. And they can also use that mouthpiece to do lung volume recruitment, using their glottis to hold sequential breaths and build their lung volumes up to, again, what we call the maximum insufflation capacity. So they can generate big differences between their own capacity and this larger MIC. So they can sustain ventilation all day using the mouthpiece, and then they can use their mask at night. We also make it very, very clear to them. In fact, each visit that I have with them in clinic, I make sure that they're still comfortable with this approach, because it's not done in many areas in the world, and folks need to understand that some people would view them as risk takers, and it's important that they have a resuscitation bag with them at all times, and they need to be attended at all times by someone who's familiar with use of the resuscitation bag. Because if they have a technical problem, if they actually lost contact with their mouthpiece, they could asphyxiate and die. So they need to have somebody monitoring them, at least present, to be able to use the resuscitation bag if necessary. There also are alarms on the ventilator, so that if there's a disconnect, the alarm will go off. But in spite of that, this is a technique of ventilation which can prevent the need for a tracheostomy, which is a huge imposition on the individual and the family. If they're in hospital, a tracheostomy may prevent them from being able to go home. It may commit them to long-term institutional care. And care 24 hours a day with non-invasive ventilation is less complicated and less costly. So every individual that I look after who uses mouthpiece ventilation consistently says that they're happy with the approach that they're taking. They do not want to have a tracheostomy, and they can live for years and years that way.
So if they use this mouthpiece, they don't have to stay in hospital, but they do have to have someone with them 100% of the time.
Yes, essentially. If this is introduced in hospital, and in so doing we are able to remove a tracheostomy, for example, then they're much more likely to be able to go home. But yes, they do have to be accompanied, virtually 24 hours a day.
So you mentioned that ALS is going to affect my swallowing. Can you tell me more about that?
As any muscle in the body can be affected, so too can the muscles that are involved in swallowing. The tongue, the muscles in the pharynx, the muscles that help you chew. So you have difficulty chewing food, you have difficulty propelling it into the back of the throat, and then when the esophagus needs to take over and move that bolus of food or liquid down, that may be weakened as well. So gradually there may be greater difficulties swallowing safely. And if everything you swallow ends up in your windpipe, in your airway, then that's very, very uncomfortable and can in fact be a risk for pneumonia or even aspiration and respiratory failure. So unless the condition is reversible, and we know of course in ALS this is not the case, then often what's called a PEG tube or a percutaneous endoscopic gastrostomy tube is recommended. So this is a tube that's inserted through the abdominal wall directly into the stomach. Much like a gastroenterologist might look for a stomach ulcer, for example, with a little lighted telescope and an endoscope. They look down into the stomach. They find a good place on the abdomen to introduce the tube, and then they leave the tube in place with a little bumper that keeps it from being removed. So it's a minor surgical procedure. And there are reasons why this might be recommended. If one's having difficulty swallowing and choking on virtually everything that they put in their mouth, then that's a clear reason as to why you might want to take all your nutrition and your hydration through a tube so that you avoid that choking. The other reason is not quite as obvious, and that's simple pulmonary function. So even in someone who may not be having difficulties swallowing, we're monitoring their pulmonary function. And in ALS, it's agreed to that a vital capacity around 50% is a good time to talk about introducing a feeding tube if that's what someone desires. The reason for that is that it's a small wound in the upper abdomen, and it's right close to the diaphragm. So if that's uncomfortable, you don't breathe as deeply, you don't cough as strongly, so there are risks for respiratory consequences like pneumonia or even respiratory failure if you wait too long and there's less respiratory reserve. So some people we recommend having a PEG tube even when they're not having difficulty swallowing, simply because their pulmonary function is declining.
With the trouble that you mentioned that I'm going to have swallowing, like, do I have to worry about choking to death?
Yeah, that's a really common and totally understandable concern for individuals with ALS. The truth is that it probably happens incredibly rarely. There are some international studies that in fact have demonstrated that no patient that they studied actually died as a result of a choking spell. Mm-hmm. And in fact, small changes in what you eat and how you eat are beneficial in preventing choking. When one moves to PEG tube feeding, then choking is virtually impossible because all of the fluid and nutrition is being taken through the stomach and not in the upper airway. Small minor choking spells do happen, particularly early on when people have not made changes in their nutrition or hydration. But later on, they really are felt to be quite uncommon. So this understandable fear is really not something that happens very commonly at all.
That's a relief.
That even life-prolonging therapies like ventilation, at least in Canada, can be discontinued, even if it means that one will die as a result. If one has the capacity to make that decision and understands the implications, one doesn't have to feel that they're going to be trapped into mechanical support, and not have the ability to relieve themselves of that.